Good day, everybody. I thank you for participating to this webinar, which was organized by the Swiss Society of Nuclear Medicine and from the Cardiovascular Committee of this society with the invaluable help of Siemens, who helped us to organize this webinar. And I would like to briefly introduce you the topic, which is the hybrid imaging and cardiovascular imaging. I think it's undoubtedly clear that hybrid imaging has a great potential both for the present but also for the future for many applications because of their invaluable capability to investigate both functional and anatomical aspects of a disease. And I'm really pleased to have here two very skilled and renowned speakers, so Professor Christoph Rispler von Universitätsklinikum Hessen und Dr. Ronny Büchel von Universitätsspital Zürich. And they will speak about various applications of hybrid imaging, PET-CT, so PET and computed tomography, and PET and magnetic resonance. So I firstly would like to tell you all that you can also ask questions during the presentations, but please, if you make a question, please write in the chat by clicking at moderator only in a private way. Otherwise, all other participants will see your question and I don't know, maybe for privacy reason, it's not exactly what you would like to do and to have. So I thank you very much, Ronny, for the first time, for participating and to accept our invitation. And please, Ronny, you are free to start your presentation.
Thank you very much, Federico. Dear colleagues, ladies and gentlemen, it is a great pleasure, my pleasure, to start with the first part of this webinar, which will be on the merits or the role of hybrid imaging using CT coronary angiography and PET myocardial imaging, perfusion imaging in the setting of coronary artery disease. Now, these are my disclosures. Now, given the fact that I know that we have attendees from the nuclear field here as well as cardiologists, I would like to start with some background information first on how PET myocardial perfusion imaging works and also a little bit on how CT works before we then get into more detail on the hybrid imaging itself. So what is really important to know is when it comes to PET myocardial perfusion imaging is that the tracers that we are using, which could be 15O water, 13N ammonia, or rubidium, that they have very short half-lives. And that means that we have to produce them on site using either a cyclotron or in the case of rubidium with a generator. So it's technically quite demanding to perform these examinations. When it comes to the acquisition protocol, that is quite similar to what we also do when we do SPECT myocardial perfusion imaging. We do perform a stress acquisition as well as a rest acquisition. Could also be the other way around. Whenever we do PET imaging, we usually do pharmacological stress with either adenosine or regadenoson. And then the data acquisition that we do perform during stress or rest, we can reconstruct to get different results. When we do the static reconstruction or the gated reconstruction, we get images that look like this one here, where we do have a three-dimensional volume that shows us the retention of the tracer within the left ventricular myocardium. We always have stress data sets as well as rest data sets vis-a-vis each other. Always at the top is the stress images, at the bottom is the rest images. We do have short axis slices, we do have vertical and horizontal long axis slices, and we also do have these polar plots here, again, stress at the top, rest at the bottom. And what you can easily see here in this patient is that we do have a relatively decreased perfusion or tracer retention here in the anterior wall, as well as in the anteroseptal wall, which reflects ischemia in this patient. And you may say this looks very much like SPECT imaging, and you are right. But what you have may noticed is that the spatial resolution is much higher. The contrast resolution is much higher. We have much more accurate attenuation correction. And what I think is important too is that the radiation dose exposure from PET imaging is much lower than what we get from SPECT imaging. For ammonia perfusion imaging, for example, for the entire examination, it ranges somewhere between 1 and 3 millisieverts, so it's quite low. But what really puts PET ahead of other myocardial perfusion, non-invasive myocardial perfusion imaging modalities is the fact that we can not only create these relative or semi-quantitative images that depict the retention of the tracer in the myocardium that we have just seen, but we can also acquire quantitative data. And for that, we need the dynamic reconstruction, the very early part. You have to imagine that the patient is already lying in the scanner when we do the adenosine or regadenoson stress. The acquisition is already started when we inject the PET perfusion tracer, and that allows us not only to visualize how the tracer passes through the right ventricle or the left ventricle, and then finally accumulates in the left ventricular myocardium, but we can also measure that. And if we measure, we can create input curves. And with these input curves, we are then finally able to calculate the absolute quantitative values of myocardial blood flow. And this is what such an analysis looks like. This is the same patient of whom we have already seen the semi-quantitative images to the right here. But contrary to the semi-quantitative images, where the numbers here in these segments stand for relative uptake, normalized to the maximum uptake, we do have in the quantitative analysis numbers that actually reflect the absolute values. For rest flow here, for example, we do have 0.98 milliliter per gram per minute myocardial blood flow in the apex here. And then you can see that during adenosine stress in this case, that this increases. This is the stress myocardial perfusion quantitative analysis here, that it increases and it results in a myocardial flow reserve or coronary flow reserve. However, personally, I prefer the term myocardial flow reserve. For ammonia, for example, you want to have during adenosine stress a stress myocardial blood flow that is above 2.2 milliliters per minute per gram, or in a myocardial flow reserve, which is above 2. Let me give you an example how this can be very helpful in clinical routine. Now, in semi-quantitative visual analysis of perfusion and function has, of course, been the cornerstone of image interpretation for a very long time. These are relative or semi-quantitative images that you see here of a patient, stress at the top, rest at the bottom. This is completely normal. The sum difference score is 0. You can see some apical thinning here. This is completely normal. So this, if you would only have this semi-quantitative image, you would say this is a normal case, no ischemia, no scar. But if you then add the numbers from the quantitative analysis, you then see that the hyperemic blood flow, the stress flow here, results in a global stress myocardial blood flow in only 1.25 milliliters per minute per gram, which results then in a myocardial flow reserve way below 2. In fact, here it's only 1.6, which is severely pathologic. And the reason for that is that in these patients, there's balanced ischemia due to 3-vessel disease, which has been shown afterwards when the patient was sent to the cath lab. You can see that this patient has high-grade stenosis in all 3 coronary epicardial vessels, LAD, left circumflex, RCA. So you must assume that the patient has balanced ischemia, which is not reflected in these relative images because there is no relative difference in flow. It's all bad, so to say. So this increases our sensitivity if we add the quantitative analysis here. But then in another patient like this one here, again, the semi-quantitative images, clear-cut case, obviously there is a relative perfusion deficit here in the infraseptal wall, which is reversible. So this is quite large area of ischemia in the infraseptal wall. But in this patient, we already knew the coronary anatomy. And obviously, the stenosis in the right coronary artery here, 70 to 90%, accounts for the ischemia that we see in the infraseptal wall. The question now is, of course, whether these lesions in the LAD and the circumflex, whether they cause ischemia as well, but balanced ischemia that we cannot depict. And it's only through the quantitative image analysis that we can really tell that these lesions are not hemodynamically relevant, in fact, because the myocardial flow reserve that you can see here in the anterior wall, as well as in the lateral wall, is completely normal. So it's only this lesion down here in the right coronary artery that causes ischemia. So this increased our confidence. Of course, there's a vast amount of literature now on the diagnostic accuracy, single center studies, this one from our own center here showing nicely how the quantitative analysis increases our sensitivity, as we have just seen in the first case. But there's also a multitude of cross-modality studies now, meta-analysis even, that have, by the way, almost all of them consistently shown that PET perfusion imaging surpasses all other non-invasive imaging modalities when it comes to the diagnostic accuracy. And importantly, there's also information, valuable information from quantitative PET myocardial perfusion imaging in terms of prognostic relevance here. The myocardial flow reserve is a strong predictor of major adverse cardiac events, cardiac death, and also all-cause mortality. Now, CT coronary angiography is the counterpart, so to say, for this webinar at least. I will not go into the technical details here. But when we do perform CT coronary angiography, of course, we can get a 3-dimensional assessment of the cardiac and coronary anatomy and morphology. We can perform three-dimensional renderings here. We can also acquire or reconstruct multiplanar curved reconstructions from each coronary vessel here, LAD, circumflex, and RCA. And if you get a case like this, of course, you can then exclude coronary artery disease. There's no calcification, no plaque, no whatsoever, completely normal coronary anatomy. You can exclude coronary artery disease in less than 30 minutes and at a very low radiation dose exposure. In other cases, you might see coronary plaque, like in this case here in the proximal LAD. There is obviously a lesion here, a mixed plaque. You can see the short cross-section here of this plaque, but you can also see that this is not obstructing the lumen more than 50%. This is maybe 20 to 30% lesion here. So again, we have excluded obstructive coronary artery disease, again, in a very short time and at a very low radiation dose exposure. It has been shown many times that coronary CT angiography has a very, very high sensitivity to detect coronary artery disease. And given a population with a low to moderate pretest probability, that then results in a very high negative predictive value, which is close to 100%. So it's a very good modality to exclude coronary artery disease. Now let's get into more detail a bit about sequential imaging or hybrid imaging using CT and PET. And the first scenario is the one where we suspect coronary artery disease. And what we have to be really aware of here in a setting where we suspect coronary artery disease is the pretest probability. The table that you see here is from the current ESC guidelines on the management of chronic coronary syndromes. And according to the typicality of symptoms, which you can see here, the gender and the age, we can now read the pretest probability. And what is really striking here is that the pretest probability in general is very low for a patient to have coronary artery disease as the cause for typical symptoms. Even in a patient, in a male patient with typical angina here, 60 to 70 years old, it's still lower than 50%. And in the vast majority of patients, it's lower than 50%. And what that means is that in the vast majority of patients, we need to exclude coronary artery disease. It's not about confirming the diagnosis, but it's about excluding the diagnosis. And that's why, and that's what the guidelines state as well, is that in the majority of patients, we need a modality that can, with a high certainty, exclude the disease, and that would be coronary CT angiography as a first-line imaging modality in a multitude of patients. However, the problems start when we do have a patient like this one here, where we again do have some plaques here in all three vessels, but then particularly in the LAD here in the middle or proximal medial part of the LAD, there's a lesion. Again, the cross-section here, where you can see that this causes a stenosis here, about 50 to 70%, I would say. And the question is this causing ischemia? And the problem we have with CT and any anatomical or morphological modality, imaging modality, is that we simply cannot tell. This has been shown even 30 years ago. Some of these publications very prominently published here in the New England Journal of Medicine. All these studies have shown that there's only a very weak correlation between stenosis severity and hemodynamical relevance or ischemia. I like one study, I think one study is very nice here from the FAME trial. What you do see here is the fractional flow reserve, which is a measure that is acquired invasively, where we simply measure the pressure drop along a stenosis. If that pressure drop is more than 20%, that means the stenosis is causing ischemia. And if we correlate that with the stenosis severity, we can see that in very high-grade stenosis, 90 to 99%, that in the vast majority of these patients, the FFR, the fractional flow reserve, is below 0.8. So that means these lesions cause ischemia, which is not very surprising. In a high-grade stenosis setting, 70 to 90% stenosis, 80% of these lesions cause ischemia. But that also means that 1 in 5 patients who has quite a high-grade stenosis does not have ischemia. And it gets even worse or more problematic if we look at these lesions that are intermediate, 50 to 70% stenosis, as in the case that we have just seen. Only about a third of these patients have ischemia. And the problem is we don't know which ones. We cannot look at the lesion and identify those patients who have ischemia. And that's why whenever we do have a patient with a stenosis on CT coronary angiography, we need additional functional imaging. For example, in this patient with a quite high-grade stenosis in the proximal LAD, we want to know whether it causes ischemia. In this patient, for whatever reason, it does not cause ischemia. This patient does not have ischemia as a potential cause for his symptoms if he or she did have symptoms. However, looking at a very similar patient, again, a high-grade stenosis in the LAD here, this causes severe ischemia encompassing almost half of the myocardium. And that is only possible to depict through functional imaging. And it's important because if we look at the prognostic value of sequential imaging using CT or CT plus water whenever there is a stenosis, this is quite a large study from Finland. We see that these patients that have normal coronary CT angiography or non-obstructive lesions during CT coronary angiography, that they fare quite well. They have a very low annual rate of adverse events. The ones patients that have stenosis on CT have a significantly higher rate of adverse events. But it's only when we do perform additional perfusion imaging, in this case with 15O water, that we can better stratify these patients into ones that have stenosis but normal perfusion, which then have a similar rate of adverse events as the ones with non-obstructive coronary lesions, and into these patients that really have or are at higher risk. And it's also when it comes to treatment management or patient management, it's important because we know that if we do not have ischemia, that revascularization does not confer any prognostic benefit. This has been shown many times. And there's a large body of evidence that shows that in case of moderate to large ischemia, that it seems to be beneficial for the patient, actually, if we do revascularize them. Let me show you a few studies that have shown these retrospective studies, actually, but very large retrospective studies. SPECT studies here with almost 15,000 patients, 10,000 patients here, and the newer one with a PET here, 16,000 patients. And all of these studies have quite consistently shown that at a certain threshold of ischemia, lying somewhere in the range of 10 to 15% of the entire myocardium, that at that point or above, early revascularization is more beneficial in terms of the prognosis for the patients than medical therapy. So whenever a patient has ischemia of more than 10 to 15%, you probably want to revascularize that lesion that causes the ischemia. The other setting where CT and PET imaging can be very helpful, and especially the hybrid imaging, diffused hybrid imaging, is when it comes to guiding treatment actually in a situation potentially of known coronary artery disease. If we do functional imaging only, and we do have the polar plots that you may very well know here, then we usually apply the standard segmentation model, telling us which vessel is subtending which area of the myocardium. This is the standard segment model here on your left. The LAD in the standard segment model is subtending the areas in red, circumflex the ones in blue, and the right coronary artery the ones in green. But you can already see that if we do apply individualized segmentation, that this is not always true. In this patient here, the entire inferior wall in yellow is actually not subtended by the right coronary artery, but rather by the circumflex artery. So in fact, this is the true individualized segmentation here, and this is wrong. This has been also shown in several studies, one being the hybrid imaging sub-study of the eVinci trial, where in fact it was shown that almost 1 in 5 entire perfusion defects due to that individualized segmentation had to be reassigned from one vessel to the other. In most cases from the RCA to the circumflex or vice versa, but sometimes also between circumflex and LAD. And that is important, again, because we only want to stent or treat and revascularize those lesions that are actually causing ischemia. Let me give you an example here, a CT coronary angiography. That patient has 2 lesions, one in the LAD here, and another one in the very proximal part of the second diagonal branch, both of them around 50 to 70%. So the first question is it causing ischemia? And from what we have seen from the sequential imaging part of this presentation, we need to perform functional imaging. And we did perform functional imaging, and we can quite clearly identify that this patient obviously has a reversible perfusion defect in the anterolateral wall here. This is a 20-segment model. So this is about 10 to maybe 15% of ischemia here in the anterolateral wall. So this probably should be revascularized to improve the prognosis of the patient. The question is, which vessel is causing it? Is it the LAD or is it the second diagonal branch? And that's really where true fused hybrid imaging comes into play. Because if we look at that, at the fused hybrid imaging, we can easily see which vessel is causing the ischemia. It's obviously the second diagonal branch here that's causing the ischemia, but not the LAD. So the LAD does not need treatment, but the second diagonal branch. Let me give you another example here, an example where hybrid imaging can be helpful in a setting where we already know the coronary anatomy. In this patient, invasive coronary angiography was performed first. You can see that the patient has a stenosis in the very proximal circumflex here, 50 to 70%. Then there's another stenosis in the very proximal part of the LAD, around 50% borderline. And then you can see that the patient also obviously has a problem with the right coronary artery here. For one, it was very difficult to even depict the right coronary artery, and it seems to be occluded here. But at that point, the interventionalist didn't really know what he or she should do next, and that's why he or she stopped, and we did perform hybrid imaging. What we did first was a CT coronary angiography, and you can easily see here in the three-dimensional rendered volume depiction the reason why it was difficult to depict the right coronary artery. The patient obviously does have a coronary anomaly here with the right coronary artery originating from the left coronary sinus. And then if you look at the various vessels, we can see that the right coronary artery is obviously occluded, and we can see heavily calcified lesions here in the LAD as well as in the circumflex. And of course, we did perform additional functional imaging, PET imaging. Again, you can see that the patient has a quite severe reversible perfusion defect in the infraseptal wall. This is the patient that we have already seen. And what really is important then, and what is really helpful, is fusing those data sets, because there's similar things, as several things we can note here. For one, not very surprising, the right coronary artery is responsible for the vast majority, or the greatest amount of ischemia that we see here, encompassing in almost the entire inferior wall. What is surprising, however, is that despite the fact that the circumflex artery showed a 50 to 70% stenosis, this is not causing ischemia here in the lateral wall. What is, however, also causing ischemia is the LAD here. You can see the LAD only had a borderline lesion, but it's actually causing ischemia in the very inferior or inferoapical area of the left ventricular myocardium. And that's, I think, a nice example of how hybrid imaging can be helpful to guide treatment or guide revascularization. And it's something that can be very easily done. We don't even need a hybrid scanner for that. We can use software-based fusion, where you basically, whenever you do have a three-dimensional data set, you do a manual co-registration. This is actually simply using the mouse and trying to cover or trying to get a good co-registration between the two data sets. And then we do a volume rendering of the SPECT or PET data set. We do a volume rendering of the coronary tree from CT, and we get those hybrid images. And that allows us, that software-based solution allows us to basically fuse pretty much everything that we want. The possibilities are virtually endless whenever we do have a three-dimensional data set. Obviously, in the setting of coronary artery disease, it makes most sense and it's most helpful if we combine a data set that gives us information on the anatomy or morphology, which is in most cases CT coronary angiography, plus function. And that could be a stress echo, for example, and we get a hybrid image with CT and echo. It could be CT coronary angiography plus CT perfusion. If you happen to be able to perform MR perfusion in a three-dimensional way, you could also do CT plus MR perfusion. In clinical routine, what we do most often is we use CT plus SPECT perfusion or CT plus PET perfusion, but it could also be FDG PET for viability assessment. And with that, I hope I could show you a little bit the merits of hybrid imaging. And I think we have come quite a long way from 2010, 2001, about 20 years ago, when we did the first hybrid images, to the very, I believe, striking images that we can create nowadays in order to not only identify those patients with coronary artery disease, but also help to find the optimal treatment strategy for patients with known coronary artery disease. Thank you very much.
So I thank you very much, Ronnie, for your excellent presentation. And
I think we are still waiting for our moderator, who hopefully will be back shortly.
I think it's here.
In the meantime, you can think of some questions that you hopefully have.
I'm here, Ronnie, and I just have to make a question. Can you hear me, Ronnie?
Are there any questions? If so, you can easily write them in the chats.
We can hear you, Federico.
Okay, perfect. So it was just a question of Ronnie. So I think I will ask a question for Ronnie if nobody else wants to make one. So, and otherwise I will also write in the chat if it cannot hear me. But I would like to know, you have elegantly shown that a perfect co-registration may be needed if you really need to assign the corresponding ischemia to the relevant vascular territory. But the question I would like to ask you is, in which categories of patients would you suggest to have a perfect assignment of the vascular territory? So the first example I would think of is if you have a residual stenosis after a coronary angiography, and the cardiologist really want to know whether these residual stenosis also causes a significant ischemia. But other authors may also think about bypass, because of course, in a situation where you have a bypass operation, then the vascular anatomy is completely different from the normal. So what do you think about it?
You make a very good point, Federico. Thank you. I think the hybrid imaging is most valuable, obviously, in those patients where we have a complex coronary situation, a situation where it might not be very easy for the interventionalist to even perform the intervention, let alone know exactly where to do it. I'm thinking of bypass patients that have been previously stented, maybe have some occluded vessels, maybe with collaterals, and so on. So those are the situations that may be very, very tricky to even do the revascularizations. And in these situations, it may be very helpful. And I see it a lot that we have patients that do undergo invasive coronary angiography, and the interventionalist at some point decides to stop and first not do any revascularization, but first do really the hybrid imaging in order to then really get a better understanding what needs to be done and if it's even possible to be done. So it's the complex situations where it's most helpful.
Thank you. I have a little question from a participant. He asks you if you can merge coronary flow reserve data with the PET, also with the three-dimensional rendering.
You mean the parametric data set with,
yes, exactly.
with CT coronary? Yes, you can. Yes, you can. That's not a problem. What I have shown in my presentation is the relative or semi-quantitative data sets that have been merged, but you can do the same thing also with the parametric maps. That's not a problem, absolutely, if that is helpful.
Okay. So thank you very much, Ronnie. There are no other questions at the moment. Of course, if somebody else is willing to make another question, maybe we can also forward them to the end of this presentation. And I would like now to introduce the second speaker, so Professor Christoph Rischler from the Universitätsklinikum Essen. And he will tell us the new advances on hybrid PET-MR imaging. So please, Christoph, it's your turn.
Dear Federico, thank you very much for the kind introduction. So I'm going to talk about PET-MR hybrid imaging in heart failure and cardiac inflammation today. And it's quite interesting because I'm going to start my talk how Ronnie ended the talk, because I would like to set the evolution of medical imaging in nuclear cardiology into the automobile industry. So let's have a look at the first car in the world, which was produced in 1885. It was a Benz Patent Motorwagen. And let's look where we have come today. So today we have futuristic cars with completely self-driving capabilities. And let's compare this now how we evolved in nuclear cardiology. So automobile industry took about 150 years. And in the nuclear cardiology, we started in 1964. This is actually the first report of a nuclear heart scan. And what they did is they imaged patients with the suspicion of myocardial infarction and injected cesium-131, which is a tracer, a beta emitter, 10 days half-life. We still use it today, but for brachytherapy. And back then, you also only got these black dots, which you can see here. And to see where these black dots are, you had to overlay the image with a chest X-ray. And so you can see in this patient, he actually had a myocardial infarction here of the anterior wall. And if we now look where we have come about 50 years later, we see that we have now integrated PET-MRI, a technique which has long been seen not to be possible, actually. And with this PET-MRI, we can get kind of the whole picture of the heart. We can do molecular imaging using PET. We can do tissue characterization with MRI, and also get information about the pump function of the heart. And today I'm going to talk about how we can use this technique for heart failure imaging and inflammation imaging. Let's start with the heart failure imaging. Usually for this purpose, we want to see if the myocardium is viable when we look at the PET. And the problem here is that the heart has a quite variable energy metabolism. So if you look at the heart in the resting state, you only have glucose metabolism of about 10 to 40% of the energy. If you now inject FDG, you have a really variable image of the heart. So what you want to do is that you want to push the heart into the glucose metabolism, and you do this by giving either glucose as a drink or even inject glucose together with insulin, a so-called hyperinsulinemic euglycemic clamp technique. And by that, you can really increase the FDG uptake of the heart and get nice images like that. And then you can really see if the heart, if the myocardium is viable. And here is an example of such a study. So this is a patient who was imaged after myocardial infarction. We actually did both perfusion imaging using PET. As you can see here, he had a decreased perfusion of the interior wall, and also a decreased FDG uptake, decreased glucose metabolism of the anterior wall. And when you look at the MRI images, you can see also here in the MRI that here in the anterior wall, you have kind of a fuzzy, hazy image compared to the inferior wall, where you have completely viable myocardium. And also in the wall motion images, you can see these wall motion abnormalities in the same area. So you can really get like a multimodal image of the heart, which allows to do a lot of nice studies. And I want to show you one of our first studies, which we actually did in using FDG PET MRI, and those were patients early after myocardial infarction. So we imaged patients after myocardial infarction using FDG PET MRI, and then we performed a follow-up 6 months later by MRI only. And here you can see an example of those images which we saw. So, and the interesting thing was that we saw different patterns when we compared the PET and the MRI part. And you can see here, for example, when you look at the white arrow, we had areas of the heart where we had both vital PET and also viable MRI data. So they were both the same in the both modalities. Then we had areas which were non-vital on PET and also non-vital, so transmural scarring on the late gadolinium enhancement images on the MRI. And so they were also both the same, but then we had this discordant pattern, which you can see here. So we had absent or severely reduced FDG metabolism of the anterior wall, indicating non-vital myocardium, but at the same time, the MRI, we only had non-transmural scarring. So we wanted to look if these different patterns have an influence on how the patients develop, if they run into heart failure or if they recover. And you can see the data here. So you can see that those patients who had, or those wall motion segments, those areas that were vital both on PET and MRI, they tended to show a higher recovery, which you can see here, compared to those myocardial segments which were non-vital both on PET and on MRI. And interestingly, those discordant segments, they were kind of in between, but more on the non-vital sides, though they also tended more not to recover after revascularization when you looked at the heart 6 months later. And we believe that this may be a way to better risk stratify patients if they go into heart failure or if they're going to recover. Another very interesting application field for FDG PET MRI are the so-called CTOs, so the chronic total occlusions of the coronary arteries. And you can see one example here on the left side. So you can see that here actually the LAD stops at this point, and oftentimes the myocardium is still vital in those chronic total occlusions, because the myocardial is then supplied by collaterals from another artery. So why do the cardiologists not just open up the vessel and look if it's worth doing it? The problem is that it's quite complicated to reopen those vessels. You have a risk of a great contrast volume, so the patient may often run into kidney failure. Then you have longer fluoroscopy times, which causes high radiation doses, and obviously you also have higher MACE rates because you have to kind of stick through this blockage of the coronary artery and can dissect the coronary artery, for example. So usually the cardiologists do not really like this procedure a lot because it takes a long time and has a high risk. So these patients are really interesting for FDG PET-MRI imaging. And I want to show exactly this patient, how what we saw on the images. This is still a perfusion image. This is SPECT images. So the patient got first a SPECT image, and as you can see here in the upper row, you can see the stress images. In the bottom row, the rest images that we have actually here in the apex, non-perfusion both at stress and at rest. So you would think when you look at these images, oh, that's quite a scar there. But then when I show you the FDG images, you can see that actually this is still vital myocardium. You have really a high glucose metabolism in this area. And when you compare it to the rest of the myocardium, you can even see that it's upregulated. So it's hibernating myocardium. When we look at the MR images, we see other interesting details. So the myocardium is really thinned out in this area, and you have even the impression that there's some scarring there, probably from the long-lasting ischemia. And so this patient was then revascularized. We told the cardiologist you should really open up the vessel. And here you can see the images of this patient. As you can see, he had at baseline, he had here this wall motion abnormality in the apical area. And at follow-up, this was completely gone, and the patient really had a benefit of the procedure. So what we did is we did more of those patients in a prospective trial. So we looked at patients who had a CTO of a relevant coronary artery. They got an FDG PET-MRI within 6 weeks of the intervention. And then 3 to 6 months later, we did an MRI again to see if the patient had a benefit of the procedure. And we found those data here. So we had in total in our patients, we had 81 wall motion abnormalities, so segments with wall motion abnormalities, and about 70% of those segments we had the same data on PET and MRI. They were both vital, but on the other hand, we had like about 25% that the myocardial segment was vital on PET, but non-vital on MRI. And interestingly, when we looked at the wall motion recovery, the FDG vital segments tended to recover, and also, paradoxically, the LGE, late guideline enhancement, non-vital segments. And when we looked into the integrated analysis, we still found this. So those segments that showed a discrepant finding, so FDG vital, LGE non-vital, they also tended to recover. And we think that exactly those patients which, like I just showed you before, where you have the thinning and also subendocardial late enhancement, that those patients benefit most from the procedure. And PET-MRI is really nice in those images to risk stratify the patients who benefit from this procedure, from CTO revascularization because of the high risk there. Another study which we did in those patients with CTO is shown here. So what we did there is we wanted to use the PET-MRI data, or basically the MRI data, to perform motion correction. So to use the MRI sequence to perform motion correction both of the MRI and the PET data. And you can see the result here on the right side. So those is a patient also from this CTO trial. He had some scarring here of the inferior wall, which you can see here. And those are the non-motion corrected images. And they are not really sharp. And you can guess that there is kind of a decreased glucose metabolism of the inferior wall. But then when you look at the motion corrected images, you can see that it's much sharper. You get much more details here, and that you can see that there's still a bridge of vital myocardium. And I think even more impressive are the MRI images. So those are MR angiography images without any contrast. And you can see the images here before motion correction and afterwards. And you can really get nice images here of the coronary arteries. And here's also a comparison of a coronary artery between MRI angiography and also the cath. And I believe that these images show the potential of the hybrid PET-MRI in those patients. And as a brief outlook, I believe, or I could imagine, that soon we will be able to not only do MRI angiography with a PET-MRI and also do PET imaging of the vessel itself, not of the myocardium, but also of the vessel itself, so that you can really identify the vulnerable vessel which you want to revascularize or to open up. But so far as I know, there are no data out there yet on this idea. So let's move on now to inflammation imaging. And first, I want to talk again about myocardial infarction. And you might ask, why is he talking about myocardial infarction? This is not an inflammatory disease. Well, we know that the left ventricular remodeling after myocardial infarction, it depends on inflammatory processes. We know that there are well-known factors which drive the heart after infarction into heart failure. Those are the extent and the location of infarction, and also the left ventricular loading conditions, but also this inflammatory healing process in the heart after infarction. And we wanted to image exactly this inflammatory process after infarction. And for this purpose, we have to prepare the patients in a different way. These patients, you do not want that the myocardium itself takes up the glucose. You want the inflammatory cells to take up the FDG. So for this purpose, you try to suppress the glucose metabolism of the heart, and you do this by different approaches. You give the patient a high-fat, low-carb diet the day before the scan. We also ask the patient to fast for a long time, for at least 12 hours. And then we also inject heparin, because this further increases the free fatty acids in the blood. When you then inject FDG, a healthy heart looks like that. So you have no FDG uptake in the heart. There's no inflammation. If there would be inflammation, you would see a spot of FDG uptake. And here is now an example of the patients which we imaged after infarction. So this patient had infarction of the inferior wall, as you can see here on the LG images, and he had really increased FDG uptake, indicating this inflammatory response. And these patients, we performed again initial wall motion analysis and also at follow-up 6 months later. And here we found that this inflammatory healing process of the heart is really important. So in our patient population, we found that the intensity of the FDG uptake there in this infarct area was the best predictor if the heart is going into heart failure or if it will recover. It was better and also independent of the scar, which we assessed by LGE imaging. And again, we think that FDG PET-MRI may be really valuable in these patients to better risk stratify patients if they go into heart failure or not. Often I get the question when I show these images, well, this is glucose metabolism. How can you say that this is really inflammation? And there are already data out there. This is from our side. So we imaged patients after infarction also with a tracer which traces the chemokine receptor 4. The tracer is called gallium-68 pentixer-4, and this tracer binds to the chemokine receptor 4. And this receptor is upregulated on inflammatory cells, for example, on activated macrophages. And in this patient, you can see that he has here the scar, also some thrombus here, and he has intense uptake of the tracer, indicating this inflammatory response. So I really believe that this may be also valuable for the future to see if this is worth to look at the inflammatory response after infarction. Let's look at another inflammatory disease. Let's look at myocarditis. And I also want to show you some cases for this disease. So first, kind of a classic case. This was a patient who had the suspicion of myocarditis. And when you looked at the MRI images alone, it becomes quite clear, okay, this is really suspicious of myocarditis. You can see here this late ganglion enhancement. You can see also the pericardial effusion, and also on T2 imaging, you can see the edema in the lateral wall fitting to this late ganglion enhancement here. And then when you look at the PET data, you can also see some FDG uptake here in the lateral wall, showing that there's active inflammation and this is active myocarditis. But often it is not so easy. So often you get patients like this one. He had palpitations, he had fatigue, also elevated troponin, and we had the suspicion of myocarditis. And you can see here, this is the late ganglion enhancement image of this patient, and you can see here this bright line in the university hospital. They often call such lines the UBO, the unknown bright object, because you often see this and you're not really sure what it is. And when you look at the edema images, it doesn't really look like edema in this area. So let's look at the FDG image, and now it becomes clear. So there's really increased FDG uptake there, indicating that this is active myocarditis. And this patient was follow-up later. He came back and he said, "Oh, symptoms are better. I'm doing better." And the follow-up after 9 months demonstrated also on PET that we had a decrease in FDG uptake, showing that we also could see that the symptoms, why they were getting better, the inflammation in the heart was decreasing. So let's look at another case. So this was a patient with also suspicion of myocarditis. Here are the LG images. They look completely normal. So no UBO here. Also edema images looks normal. But this patient was then biopsied because they had the suspicion of myocarditis. And as you can see, there was some infiltration of inflammatory cells, and it was myocarditis. But this is not the whole truth, which I tell you, because we did an FDG PET MRI, and we actually told the cardiologist where to biopsy and said, well, this is suspicious of myocarditis. And actually there he got the specimen and demonstrating that FDG PET MRI really has its value in those cases. So let's look at another case. Is this myocarditis patient with angina, palpitations, and fatigue? Here are the images, and you can see here these spots of LGE. Let's have a look at the PET images. And as you can see, some of you may already have noticed it. There are also enlarged lymph nodes in the bihalar region. And you can see that they have really increased FDG uptake there and also in the myocardium. And it becomes clear that this is cardiac sarcoid. And cardiac sarcoid is another very interesting application field for PET MRI. Because the important thing about cardiac sarcoid is that it's often not seen, or the patients, they come, maybe you do the diagnosis of sarcoidosis, but often it's not clear if you also have cardiac involvement of the sarcoidosis. And often, actually, there's a Japanese study which demonstrated that about 40% of the patient, they show the first time they show up to the doctor is with sudden cardiac death, because it's really often not, you have often not symptoms of this disease. So it's really important to rule out cardiac sarcoidosis. And here's one patient I want to show you for this purpose, for PET MRI and cardiac sarcoidosis. This was a patient when I was back in Munich still, and this patient, he was skiing in the Alps, and suddenly he became unconscious. They called the ambulance, and they had to resuscitate this patient. They finally got him. They brought him back to the hospital. They thought it's myocardial infarction. They looked at the coronaries, and they were completely clean. So they were not completely sure what's going on there. They had the suspicion of cardiac sarcoidosis. And so we did an FDG PET MRI in Munich. And as you can see, this patient had this really big areas of late ganglion enhancement here of the septum, inferior wall, also of parts of the right ventricle. And he clearly had also FDG uptake in this area, indicating that there's an active inflammatory disease. We told the cardiologist, well, this kind of looks like sarcoidosis, but there's one aspect which is quite uncommon. There are no lymph nodes. He had no lymph nodes in the bihalar region, no lymph nodes in the axilla. So we said it looks like cardiac sarcoidosis, but this is really uncommon. So the cardiologist went ahead, took a biopsy, and it was actually cardiac sarcoidosis. And there are really rare cases where you have cardiac sarcoidosis without any other sites of this disease. And this was such a case. This patient then was treated. He got glucocorticoids and came back. And the cardiologist asked us if we can have another look if the patient still has active cardiac sarcoidosis. This time we had to do a PET-CT because he also got an ICD. And as you can see, here's the ICD. And in the PET, you can see that there's still some active inflammation in the area. So the kind of the core here has gone, but still in the border zone there was still active inflammation. So we told the cardiologist you should go ahead and maybe intensify the therapy, and that's what they did. The patient came back a few months later, and then the inflammation was almost gone. But on the other hand, you can also see that the myocardium was thinned out here in this area compared to this. So he surely had lost some myocardium there. But this case really nicely demonstrates you that you can use the PET images or PET MRI to guide therapy also. Another very interesting study about cardiac sarcoidosis in FDG PET MRI is this study here. And what they did is they did FDG PET MRI in patients who underwent this modality for the evaluation of cardiac sarcoidosis. And they first looked at the images separately on cardiac MRI and on PET, and then said, okay, this patient has no sarcoidosis, blue, possibly sarcoidosis, red, probably sarcoidosis, this green part here, or highly probable for sarcoidosis. And they did this both for PET and MRI. And then they performed an integrated analysis, took both the images, and this is really interesting. They had to reclassify 45% of the patients. And when they looked at the whole data then, and also in the biopsies and the follow-up, they found that 80% of the patients were actually correctly reclassified. And this is one of the studies which really demonstrated that this is probably one of the so-called killer applications for cardiac PET MRI. So at the end, I want to show you one very novel thing. So this is another patient. He came now to the hospital in Essen for FDG PET MRI, and this patient had the suspicion of cardiac sarcoidosis. And you can see here, he had some spots here of late gadolinium enhancement and also some FDG uptake here. So we said, okay, this really looks like cardiac sarcoidosis. They treated the patients with glucocorticoids, and he came back later, a couple of months. And as you can see on the FDG images, the inflammation is gone completely. You can see there's now scarring at some areas, but the FDG metabolism of the heart is gone. So we would say, okay, the inflammation is gone. But the new thing about this case is that we performed FAPI imaging. So FAPI, gallium 68 FAPI is a tracer which images activated fibroblasts. And this is really interesting. As you can see, the inflammation is gone, but at the same time, you still have restructuring, remodeling processes, which you can see here on the PET images. There are a lot of fibroblasts are activated in the heart, demonstrating that this scar is not readily formed, that there's still fibroblasts activated, which really may then also cause remodeling. And I think this is one of the next big things which we will see in nuclear cardiology. So let me sum up. I think our hybrid cardiac PET MRI is a really nice thing because you get the whole image of the heart, morphology, function, biology. You can get all these different factors of the heart. You can look at the geometry. If you have fibrosis, you can even look at the vessels. Also, you get an idea of the function of the heart, and you can do molecular imaging using all different PET tracers which we have. And this increases, for example, the local interdisciplinary expertise, because we have to work together closely with the cardiologists, with the radiologists. Also increases patient compliance, because you only need one study, not a PET and a separate MRI. And as I just showed you, I think we also get an improved understanding of cardiac pathophysiology. And with this, I want to thank you for your attention.
Thank you. Thank you, Christoph, for your excellent and comprehensive presentation. I have a small question for you and regard the use of PET-MR in the assessment of patients who may benefit from revascularization. So what is, according to you, the exact role, or in your opinion, what can be the exact role of PET-MR as standalone modalities and PET-MR altogether?
So you mean in patients with, I got the first part.
Coronary artery disease, and okay. The hypothesis is that you have still viability in this subtending scar, which maybe is not a scar, but with Winterschlaf and hibernating myocardium.
Yeah. So as you may know, there are now drugs that you can give, or there are studies that show that certain drugs after myocardial infarction they lead to or cause a better outcome in the patient. There's this CANTOS trial which showed that canakinumab after myocardial infarction, it demonstrates that those patients have a better outcome. But on the other hand, these medications, obviously, they have side effects. They may have severe side effects, and some patients even die from these side effects. So I think when you do the integrated FDG PET MRI after infarction, for example, then you can risk stratify patients. Okay, this patient has a strong inflammation in the heart. This patient should get one of those novel therapies. And on the other hand, you have patients who has a really low grade of inflammation, and this patient, he does not need this novel therapies. I think this would be, for example, one real application which may come into clinics.
I also have two more questions from the audience. The first is, what do you think about PET radiotracers specifically targeting inflammatory processes, as for example, chemokine receptor 4?
Okay, yeah, I showed this one slide. We only did a few cases in Munich, but there's a large study which was really highly published from the Hannover group, from Professor Bengel, and they also showed that they saw increased chemokine receptor 4 expression after myocardial infarction, and the higher the expression was after infarction, also the patient had lower ejection fraction, so independently of the infarct size. And this also demonstrates that this tracer may be valuable in these patients to see if they are more likely to go into heart failure, or if if they will recover.
Another question is, what will be the clinical impact of the FAPE positive PET in the last patient, the last patient you showed?
Yeah, so that's a really good question. So far, I mean, there were actually drugs that targeted fibroblast activation protein. That's how we also got the tracer. So the FAPI, fibroblast activation protein inhibitors, they were used in cancer studies, but they failed basically. But it would be obviously, if we had drugs that may influence the fibroblast activation, then you could treat it. In this patient, basically we had the question was, well, we still have the suspicion there's something going on. We cannot really believe that the cardiac sarcoidosis is completely gone, and that's how this imaging was initiated. And this may be the additional value in these patients, I think.
Two more questions. I think we have time for them. The first question is, so many things coming up for sarcoidosis. What do you think is the most cost-effective imaging modality for diagnosing and follow-up?
Most cost-effective imaging modality for diagnosis and follow-up. Well, okay, the most cost-effective, there are a lot of data showing that if you do FDG PET and perfusion imaging, for example, using MIBI, I think you need these two to see if this is active in sarcoidosis, or it's already kind of non-inflammatory sarcoidosis, and if you only have scarring and no inflammation. So this is probably the most cost-effective images, PET CT low dose without any contrast, and then do a MIBI or a tetraphosmine specs together. Then you can really nicely evaluate the data. There's a lot of data from Ron Blankstein, for example, which showed that this is really, really nice.
Also, if I may add something to that question, well, we also have to keep in mind that maybe in a majority of patients, it's not about that we know that the patient has sarcoidosis and we want to now know whether the heart is affected or not, but the question is what is going on. And the good thing then about performing FDG PET is also the fact that we can exclude or include whether the myocardium is affected or not, but we can also identify those lymph nodes that are affected, and that gives us one target for biopsy, which is of course much easier to do a biopsy in a lymph node rather than in the myocardium. And when it comes to therapy monitoring, of course, the large advantage of PET is the fact that it's quantitative, that we can actually quantify the amount of inflammation that is going on.
Yes, exactly, because also we have to keep in mind that sarcoidosis is a systemic disease, not a cardiac disease. Or yes, of course, it's also a cardiac disease, but cardiac is just a manifestation of the same disease.
Absolutely.
And just another question. So is there a way to be able to differentiate between the various causes of myocardial inflammation, involvement in myocarditis, or acute scar, sarcoidosis? Can, in this aspect, the MR be of help?
Absolutely. So if I see some FDG uptake, it's sometimes hard to tell where it comes from. If you have, for example, SEP and endocardial scarring, then it's more likely that it comes from ischemia, from infarction. If you have spotty FDG uptake, and also see then in the MR images that there are some small areas of LGE, and also maybe on the T2 images edema, then you think of myocarditis. And absolutely, so if you look at the images together, then it's much easier to separate between these, to differentiate between these different diagnoses.
And also for myocarditis, do you routinely use also PET-MR also for the follow-up, or just for the diagnosis?
So still, most of the patients get an MRI, to be honest. It's well, there are a lot of data that it really works well, but if we still have questions, if the results which we get from the MRI are not clear, or the cardiologists say, oh, we do not really believe this, then we do PET-MRI together with FDG.
Okay. So thank you. I think we filled exactly the hour we planned to speak. So I think I can thank everybody for participating to this webinar. And I also, of course, thank our two speakers, Christoph and Ronny. And of course, a special thank also to the Swiss Society of Nuclear Medicine, which gave a big support to the organization of this webinar, our cardiovascular committee of the Swiss Society of Nuclear Medicine, and of course, Siemens, who helped us in organizing the committee as well, the webinar as well. So I thank you everybody for participating, and I wish you a good evening, and to the next webinar for the Swiss Society of Nuclear Medicine. Bye.
Thank you. Bye-bye.
Bye-bye. Thank you, Federico. Bye-bye.